good afternoon. Thank you for your kind invitation and congratulations for this excellent program. I have to deal about Still syndrome. You know that every fistula is stealing blood flow, which is not going to the distality. But in some cases, this induces low distal ischemia. So, Still syndrome is the consequence of the association of first still of the high pressure artery blood flow by low pressure vein, and this still is associated with an artery pathology, diabetes, atheroma, previous angioaccess, and medial calcinosis. And this is resulting in reduced distal blood flow and arterial pressure and increased peripheral vascular resistance. This is the hemodynamic of proximal arteriovenous fistula with the antegrade flow, which is partially or totally stolen by the vein, and the retrograde flow, which is not constant at the elbow. This is the hemodynamic of distal arteriovenous fistula with antegrade and retrograde flow, which are both stolen by the fistula. Retrograde flow is almost constant. Everyone knows that there is a clinical classification from stage 1 with pale blue cold hand to pain during hemodialysis to respand pain and motor dysfunction. And the last stage is ulcer, necrosis, and irreversible gangrenes. Finger pressure measurement and waveform evaluation are very important, and this is from Malik a few years ago, and this is normal waveform on the opposite side, and this is pressure and waveform uniformly lower in the AVF limb or even flat in cases of severe still. Normalization after occlusion indicates limited role of arteriopathy and is, in my opinion, a good prognostic factor. So there are many treatment options. I will discuss those that I use. The first one is arteriovenous fistula ligation, and this is the case after first stage basilic vein superficialization. The second stage will aggravate the situation, so we decide to ligate. This was a distal fistula on calcified artery in a diabetic, and arteriovenous ligation was almost successful. When you don't do arteriovenous ligation, you have to wonder if there is any artery stenosis, which could be easily treated most of the time by PTA. And this is, once again, subclavian artery stenosis treated by PTA. This is an axillary artery occlusion post-irradiation, which was recanalized. And this is an ulnar artery stenosis associated with a radial-cephalic arteriovenous fistula, and the ulnar artery was treated by angioplasty with an excellent radiologic and clinical results. The third option is fistula flow reduction when the flow of the fistula is very high. First of all, banding. Banding necessitates a major reduction of the caliber, more than 80%, whatever the technique. And there are two major postoperative risks: access thrombosis and persistent high flow. Finally, I quit with banding, and I would rather replace it by RUDI. RUDI is revision using distal inflow, another way to a more successful way to reduce flow, to reduce high flow. PTFE distalization, we reported this operation a very long time ago. You close the fistula at the elbow and you interpose a PTFE graft between distal artery and vein over the elbow. I was using that in patients with cardiac problems, and many of them were children, so I decided to replace the PTFE, which is prone to developing stenosis at the venous anastomosis, to replace it by transposition of the radial artery, as you see there. It's a rather difficult operation, especially the anastomosis between a very small artery and a large and thick vein. Of course, we always use a surgical microscope, and this is a case where it was used not for cardiac problem but for ischemia, and you can see that the result was excellent. We published about that on 47 patients, and only 8% were treated with this operation for distal ischemia. There was 28% cardiac failure, 49 asymptomatic high flow, and 15 venous hypertension. The fourth treatment option is distal revascularization, and you have to look after for distal AVF, and it's very easy, and for proximal AVF, and it's rather complicated. For distal artery, for distal radial artery ligation, it will enhance the flow and the pressure in the palmar arch, and it's very efficient if you have checked that the ulnar artery and palmar arch are patent. For proximal arteriovenous fistula, there are two major interventions, DRIL and PI. DRIL is distal revascularization interval ligation. PI is proximalization of the arterial inflow. DRIL was described first by Schanzer in 1988. He is a vascular surgeon from New York. The first thing is to insert a great saphenous vein of the patient between the upper part of the brachial artery to the distal part of the brachial artery, or to one of the distal artery. At that time, Schanzer was wondering if the flow would be stolen, would become retrograde to the fistula and be stolen, and to avoid that, he decided, which is quite unusual for an artery vascular surgeon, to ligate the brachial artery. This is one result of that operation, and I must say, well, we'll see that later on. The last operation is proximalization of the arterial inflow. PI, it was described by Zanov in 2006 and republished with excellent result in 2013. The first thing is once again to ligate the vein, to divide the vein near the anastomosis, and to interpose a PTFE, a tapered PTFE, 4 to 7 millimeter between brachial artery and cephalic vein at the elbow. So we have to discuss DRIL versus PI. From an hemodynamic point of view, both are almost similar. DRIL has been used by many surgeons without reported major complications, but you know that surgeons rarely report major complications. PI has the great advantage not to ligate the brachial artery, which could be a problem for the future if the revascularization graft thrombosed, but PTFE to vein anastomosis will develop a stenosis. But you must see that early thrombosis of the fistula are quite different, 0.6% for DRIL and 7% for PI. To finish with my presentation, I will just present the algorithm for treatment of distal ischemia. In stage 1, it's just conservative treatment. In stage 4B, you have to ligate the fistula and probably to do some sort of amputation. For the other stage, the first thing to do is to ask for both duplex and angiography. First duplex and angiography. And if there is an artery stenosis, it will be treated by PTA. In case of unsuccessful PTA, it will be treated by surgery if possible. If there is no artery stenosis, you have to rely on the flow. And for proximal AVF, if the flow is under 800, I will do a PI. Between 800 and 1,200, which is almost normal, I will do a DRIL. And over 1,200, I will do a RUDI to decrease the flow. For distal arteriovenous fistula, let me say again that it's more simple, and that the main operation is DRAL, distal radial artery ligation. There is a clinical form of distal ischemia, which is ischemic monomelic neuropathy. It is a rare, potentially disastrous form of Still syndrome after creation of an elbow fistula in an old diabetic woman. You will see an immediate apparition of major pain and distal weakness. You note that the distal pulse may be present. Perioperative ischemia of vasa nervorum at the elbow is a possible explanation. Immediate arteriovenous fistula ligation is required to have a chance to prevent irreversible neurologic deficit. For what about still for Thight angioaccesses? Diabetes and occlusive arterial disease are now a contraindication for angioaccess at Thight. The incidence rates are much more important for femoral vein transposition, 21%, than for prosthetic arteriovenous graft, 7%, and the amputation rates are from 0 to 7% according to different publications. The last form of distal ischemia is venous hypertension. It's a fistula with a downflow stenosis, and the blood stagnation induces edema, cyanosis, skin ulceration. The treatment is PTA of vein stenosis. In conclusion, PTA for artery stenosis is the first option. Efficacy of bending is controversial. The most useful techniques are DRAL for forearm fistula, DRIL for elbow fistula. Flow reduction and access ligation may be necessary. Thank you for your attention.